Hello everybody, my name is Caton Detara and I'm a diabetes doctor from Norwich in Norfolk, and I'd like to thank the organisers for allowing me to talk about this subject on the pragmatic approach to the treatment of diabetic foot infections in the UK in 2022. I'd like to start with a quote from a colleague of ours who we're all very familiar with, from Mike Edmonds, who really clearly sums it up, saying the microbiology of the diabetic foot is unique, and that's why it's actually quite difficult to try and come up with a single way of treating a foot infection, because it really depends on where you are, what the person with diabetes looks like in front of you, what their foot is like and what they previously had, what your current sensitivities are and local sensitivities are. But we'll get on to that in a few minutes. And Mike also came up with the 10 commandments of the diabetic foot, and I'd encourage you to look for this publication. And really, I want to bring your attention to this point number 4, which says, "Thou shalt carefully look for signs of infection in me and treat it aggressively." And I think the key word there is aggressively. And I'd actually say early as well. So as we all know, when we look about the diabetic foot, there are an enormous number of things to consider, as I've mentioned. It really doesn't take this audience to know about the things that contribute to the occurrence of an ulcer, and then for that to become infected. And this is just some of it put together in a little schematic to show all of the things that we need to consider when we are talking about diabetic foot infections. What I really want to show you is this slide. And this looks at the risks of hospitalizations for infections between 2007 and 2016 compared to people with and without diabetes. And it's a busy slide, but really what I want you to focus on is this column at the very left-hand side. And what you can see is that for all infections, so this is for pneumonia, both in men and women, influenza, TB, kidney infections and sepsis, the rates of infections and hospitalizations for infections is almost double in all cases of infections for people with diabetes. If, however, you look at diabetes status and risk for hospitalization compared and adjust it for all of these things that you see here on the left, then if you look again, then no diabetes being the reference group, then having diabetes increases your risk at least by 50%. But if you then look specifically at any infection, it's 0.67. If you look at foot infections, it's raised by 6 times higher if you have diabetes. So therefore, having diabetes and having a foot infection is of course bad for you. And we know from the National Diabetes Inpatient Audit that having a foot infection is the most common cause for a diabetes-specific hospital admission. These are data again from America, or published in Diabetes Care, I should say, looking at the admissions for foot infection. And if you look at the blue line in both, this is the rates for hospitalizations. But look at this. This is the logarithmic scale on both of these vertical axes, and the rates for osteomyelitis, again, significantly higher for people with diabetes compared to without diabetes. But there are a number of different challenges, as I mentioned when we went right at the beginning. What antibiotics do you choose? Do you use empirical antibiotics? Do you use targeted antibiotics? So wait for the cultures to come back. Do you cover the most common organisms? So gram-positive cocci, most frequently, of course, staphylococcus being the most common one. Who owns and who looks after what you can prescribe? So stewardship, somebody has to be in control. You don't want anybody and everybody just prescribing whatever they want. The peccadillos, if I may use that word, of the local microbiologist. There are some things that they won't let you prescribe. Of course, we have to think about C. diff. We have to think about whether osteomyelitis is present and how that will change both the antibiotics that you choose and the duration of treatment. Of course, we all have to think about costs, penicillin allergy, and all of the things that you think about there, including right at the bottom where we talk about sampling. And of course, we have to think about sampling because there was this excellent study called Codify, which compared simple superficial wound swabs to deep tissue samples. And of course, the outcome was that deep tissue samples were much more preferable in identifying infective pathogens compared to superficial wound swabs. So who does what and how it's done makes a big difference. And that's why a good podiatry team is so important as part of the multidisciplinary team. But there are so many directives and initiatives that we have available to us from a variety of different people. So this is just one from the World Health Organization. another one from Public Health England, another one from the European Union, another one from Her Majesty's Government in the United Kingdom, another one from the Royal College of General Practitioners on the targeted antibiotic toolkit, a further one from the European Union talking about the European Antibiotic Awareness Day, which happens every November, another one from Public Health England, and finally another one from the World Health Organization. But we also have this campaign called Choosing Wisely, which is a global campaign. This is just from Choosing Wisely Australia, looking at what clinicians can use in terms of choosing antibiotics. This is from Choosing Wisely Canada, a similar project. And finally, another one from the American Pediatric Medical Association, again, utilizing the Choosing Wisely banner. But let's think about what's already out there. These are a variety of different things which many of you will be familiar with, predominantly IDSA and Wagner, and also the Sinbad score, as well as the University of Texas. But the problem with all of these is that they are really wound classification and scoring systems, and they don't really talk about treatment. And what we have, of course, is the International Working Group for the Diabetic Foot, as well as the Infectious Diseases Society of America, which have given us a couple of different pathways which we can think of. But actually, they're very similar because the main author on both of those is Ben Lipsky, who is, of course, a very senior figure in the world of diabetic foot infections. So let's go back to the original document from 10 years ago now. And really, this still stands. It says don't treat a clinically uninfected foot, use an antibiotic for an appropriate wound care. You need to think about covering gram-positive cocci, and you really need to think about broad-spectrum agents when you have a moderate infection whilst you're waiting. And if you think that maybe MRSA, if you've got a high prevalence or the individuals had MRSA, then really you need to think about treating that straight away rather than waiting. And of course, you need to think about the route of administration depending on severity. And I will come back to that in a little while, particularly when it comes to admissions avoidance. And you need to treat until the resolution of infection, and of course not until wound healing, because wound healing may take months and months and months. So this is what the IDSA had in their treatment options 10 years ago. And I've put this into italics and in bold, and you see why that reason for the reasons given here. But there are a variety of different issues. This is from America. Many of the agents were not available in the UK. And if you limit them to what is available, there are certain things taken away. And then you have to consider that we work in the NHS, and so you have to think about what is cheap. And so that really limits us about what we need, what we have available to us. We have to think about what are the potential limitations to the available guidelines. And the first one, and by far and away the most important, is there's very little randomized controlled trial data to help us make decisions on. And many of the drugs that do have the randomized controlled trial data are relatively new and therefore expensive and therefore essentially unaffordable to most of us. And there is almost nothing at all in any of the guidance to talk about admissions avoidance. And in this day and age, particularly in the age of COVID, when we're all so stressed and the hospitals are so full, admissions avoidance is an absolutely key issue that we need to be thinking about. And so this is the current IDSA and International Working Group, or was, sorry, the classification for wound infections. And you can see it's uninfected, mild, moderate, and severe. And that makes a difference into how people should be treated. But what we did in Norwich is that we came up with a middle ground about moderate admissions, moderate infection, borderline. So they had certainly got evidence of borderline infection, but they were systemically well. And so what we came up with at the time, now almost 10 years ago, is that we started using intramuscular antibiotics administered by district nurses. And we found that we reduced the admission rate by half. And in those people that were admitted, their length of stay was significantly shorter. And we ended up saving an enormous amount of money. time has now moved on, and many hospitals, including ours, we now have outpatient intravenous services either going out to individuals' home, so they have a peripherally inserted central cannula, a PICC line that goes in the arm, and the district nurses or the hospital at home team go in and administer once daily intravenous antibiotics, or the patients themselves can come into our day unit and have their intravenous antibiotics given once a day, and that also saves hospital admissions. So these are still the drugs that we use predominantly. In red, we use a lot of coamoxiclav, clindamycin, clarithromycin, fluclox, and so on. And intravenously, we can use ceftriaxone, or we can use ticaplanin and penelergic together with the oral things that you see here, Cipro and Metro. So, and of course, if we give them IV, we can use the same kind of antibiotics, ceftriaxone or ticaplanin. And as a result of what we published, I'd like to think, although they may not admit it themselves, there is now, they do have a moderate to severe soft tissue infection, as you see here in table 3 on the right in their 2020 update, that they did say that there are people who may not need admission and they could be treated in alternative ways. So let's talk about individual antibiotics. Well, is coamoxiclav any good? Well, yes, there was this study published a couple of years ago now saying oral coamoxiclav is a reasonable option when treating antibiotics with diabetic foot infection and osteomyelitis. But and NICE says exactly that about osteomyelitis. If you think somebody's got osteomyelitis with a local infection and a deep wound, then treat it. And if you're concerned, obviously do plain imaging. If you're still concerned, consider an MRI scan. And there's an excellent document here from Eric Seneville and Ben Lipsky and colleagues from talking about osteomyelitis. And there are uses of old drugs. So this is one for rifampicin, published again a couple of years ago, saying rifampicin is a very good drug, did treat people much better. Osteomyelitis resolved much better in people with rifampicin than people who were given alternatives. But of course, rifampicin, you can't give it on its own. You need to give a sidal and a static. You can't just give one or the other when you're talking particularly about anti-staphylococcal agents. Well, there was an opposing point of view, of course, and this is a systematic review looking at randomized controlled trials, thinking that there's no definitive evidence for any one particular agent in the treatment of either osteomyelitis or for osteomyelitis in this particular condition. And actually, most of the studies were fairly small, not of particularly good quality, and that's why they came up with this point of view. What about the duration of treatment? Well, this is a group, as many of you know, from Switzerland who looked at different degrees of infection, so soft tissue, non-amputation osteomyelitis and post-amputation, and looked at the length of time that antibiotics were given and the rates of healing, and actually there was no differences in outcomes. And so there's no idea, we don't know whether you should be giving it for long-term or short-term. And the same group came up with this study looking at 3 weeks worth of 6 weeks, and they showed that post-debridement systemic antibiotics for diabetic foot osteomyelitis of 3 weeks was non-inferior to a course of 6 weeks. So it's a difficult one. Certainly, I would be very worried if I gave it just for 3 weeks, but I'm open to be shot down for that one. CRP, some of us use CRP, or some people use CRP as a guide to whether that can help you tell whether infection has resolved and when to withdraw antibiotics. And this data from last year shows that actually CRP is really not a very good instrument to help you determine whether infection has resolved. Oral IV, this is of course from a couple of years ago, again now the OVIVA study. But actually, Ben Lipsky, who's one of the authors on this study, I did contact him immediately and ask whether what did they do for diabetes patients with foot infections? And he told me there were not enough individuals in this study with diabetes for them to be able to make a definitive conclusion about whether you use oral IV. So that's a pity. That's a missed opportunity potentially. But there are a number of different things on the horizon. There's a whole raft of emerging agents which we could potentially use both for wound healing and of course antibiotics. Phages are really exciting. Of course, they use them in Cuba and in Eastern Europe and in Russia a lot with some success, but that data is not often in the English language, so it doesn't really come through very often. What about multi-drug resistant organisms? We've got 2 new antibiotics which were just in the news very recently, which could be used for these infections of last resort, or agents of last resort, to treat these multidisciplinary multi-drug resistant organisms. And of course, we've got other things that are coming along that could also help us. But is there good evidence for what we can do? No, not really. So, of course, the International Working Group is currently working on the 2023 guidance, which should come out just before the conference in The Hague in that year. Infections and wound healing and so on. There is work ongoing all the time. I know the groups are working, and certainly I'm involved with one of them. I'm involved in the wound healing guidance, and it's a lot of work. So these are very, very heavily evidence-based guidance. So in summary, ladies and gentlemen, I would say the microbiology of the diabetic foot is an ever-changing challenge. It's an active area. There's a lot of work going on. Your microbiologist and your podiatrist should be your best friends when you come to trying to figure out what to use, and actually always think about the use of parenteral antibiotics or your outpatient service to try and avoid admissions. And with that, I'd like to say thank you very much indeed for your attention. This presentation will be on my website, and of course, feel free to email me or tweet me. Thank you very much for your attention.